Now, depending on how many beds you have, that will dictate the number of patients you can keep or not keep.
Welcome everyone to this virtual ICU webinar presented by the IRHA and INCERN members for our members, featuring a conversation with Dr. Pratham Ghosh, Chief Medical Officer at Access Telecare, and Carrie Tressler, the Rush County Vice President of Nursing, Director of Emergency Department, and Med-Surg. My name is Phil Ellis. I'm the Network Director for the IRHA and INCERN, and I'm joined by my IRHA colleagues who help set up and manage the Zoom information. I want to thank Ali Orwig and Carolyn Miller and Sarah Larson for joining us as well. So we're very pleased to have everyone join us this morning. Many rural hospitals do not have a designated ICU. Often that's because of low patient volumes in the department present staffing challenges. However, Access Telecare, one of our longtime business partners with the IRHA, now offers this virtual ICU service that enables rural hospitals to retain patients that otherwise would have been transferred out. And we're all too familiar with the challenges of patient transfers. So keeping patients local in their hospital is a high priority. Patients want to stay local, as do their families and friends. This is a unique service now offered by Access Telecare that can make that possible. So today, I'm pleased to welcome Dr. Ghosh and Carrie to a discussion on how this service works, and they'll take you through a discussion and answer your questions afterwards. So as we begin, if you would please have your microphones muted, and then we will get started. So Dr. Ghosh, Carrie, welcome. Thank you very much for taking time to share your thoughts on this very innovative program. We appreciate you taking time to be with our members. Carrie, I want to start with you. What was behind wanting to build a virtual ICU, or what was the driving thought on that?
I think at first you could say it was COVID, but it started way before COVID. Of course, we always want to look at what's best for our patients and the families when it comes to being admitted to the hospital. But then it's also our surgery. Without having an ICU, our surgeons were less likely to perform certain surgeries here. So we kept looking at ways, working with them, trying to find ways to increase our surgery load. But they were still very hesitant not having that ICU. So that was two factors. And then, of course, once COVID came, yes, the inability to transfer. And so it was, Brad and I had many discussions, and it was just like, it's time to do this for, those three reasons. And I was at one of the IRHA conferences and ran into John Henry, started that conversation, and here we are today. And I can say that it's been easy to work with Access Telecare. They kind of helped just drive this whole experience. And as of today, our surgeries, we've had an increase in surgeries. We've had decrease in our transfers. And so it's just been a great thing for a rural hospital. And so I highly, encourage anybody that is in the same position as me as, trying to increase surgeries, decrease our transfers, and increase the patient experience to see if this is an option for them.
Okay. Did you try to do, or did you look at the potential for a traditional ICU before going with a virtual model?
As far as for us, it wasn't feasible because our hospitalist, their rotation is 7 days on, 7 days off, and we only have two of them. With being small and rural, we don't have all those extra staff members. And so to add another full-time FTE just didn't make sense for us. And that's where, this was Access Telecare was helping us bridge that gap.
So that's what led you to the final decision then to go with the virtual model. Okay, good.
Yeah, and our hospitalists, they're internalists, and so they have the knowledge and stuff. But with them having that schedule 7 days, 7 days on, 7 days off, with ICU, the care that would be required in the middle of the night I would have
Mhm.
burnt them out and they would have went running for sure, I'm sure.
I understand. I
And
understand.
so that was another thing, we have it set up where during the night, Access Telecare takes all of the ICU admits, and then in the morning, they pass it off to our hospitalist. And then
Mhm.
they're there for any guidance or any questions that they might have on those patients during the day when they're rounding. So
Okay,
it's a
good.
great partnership for sure.
Great. Thank you, Carrie. So Dr. Ghost, let me go to you. So I know just from talking with you and John that you've got hospitals all over the country that you work with on these models. You've got some that are completely virtual ICUs, some where you just provide additional support for those who might not have 24-hour coverage. But for the hospital members, sometimes it can seem like an impossibility to navigate these decisions. Do you have any specific points or information that you can offer that would make a hospital leader who's investigating, trying to decide on this, what makes sense for their hospital between the different models?
Yeah, first of all, Phil, thanks for having me. It's good to see everybody. Good to see Carrie again. Haven't seen her in a long time. So I think if you look at what makes a successful program and whether a client is a good fit for a virtual ICU program, it's really, it starts from the non-clinical side. It starts from the leadership, right? You have to have a leadership that's willing, engaged, and bought in to the concept, because the more bought in they are, the more they will meet you in the middle to make sure that the program is successful. And so with Rush, obviously Carrie led that charge, and it was evident from the beginning that this was a program they really wanted versus just maybe it's a whim of let's just see what happens, right? From a clinical side, there are two very important factors that determine whether a virtual ICU can be successful. Number one, you have to make sure they have the right equipment and the right pharmacy to mix the medications you need in an ICU, because you're looking at continuous drips, you're looking at needing ventilators, a BiPAP, different types of respiratory support machines. So you want to make sure they have the proper equipment and the right pharmacy to mix some of the medications that we need. And secondly, because we're virtual and because ICU care requires a lot of procedures, you want to make sure that there are boots on the ground that can support you in doing some of these procedures, right? We're not going to be able to come in and intubate. We're not going to be able to come in and put a central line in. And so to have invested, bought in boots on the ground that also see the value of having a virtual ICU and are willing to help you with these procedures, whether it be in the middle of the night or at 3 o'clock in the afternoon. That is a very important factor in order to have a successful virtual ICU program.
Okay, good. Thank you very much. That's helpful. Carrie, let me go to you on this next question. So once you began the program, how did Access Telecare staff work with you and with your clinical team before actually going live? So how did they get you prepared? Did they help you build your confidence and ready to launch this thing?
Oh, 100%. And like Dr. Ghosh said, it was a team effort. It wasn't just ICU, we had to have the hospitalist buy-in. We actually, at night, we worked with our emergency physicians, for those hands-on procedures. We worked with anesthesia during the day for those hands-on procedures. So they guided us and they helped us, like, don't forget this, don't forget that, as far as education for the nursing staff, that was a concern because, being rural and having med-surg experience, probably, or ER experience, a lot of them were not comfortable with ICU. So Access Telecare, they're always there to answer questions. They helped us with a formulary for pharmacy, but they were like, hey, we don't cover this medicine. And so we had those conversations. Well, what do you have? And yes, this will work. And so it was just lots of meetings in the beginning. But in the end, when we did go live, we were 90% ready. There were things that were like, oh, we didn't think about that. But they were there to guide us and help us see, well, how about this? How about that? So overall, it went well, very well.
Okay, good. So did you have reservations, you and or your staff, did you have reservations from a clinical operations standpoint that you had to get over before you launched this? That had to be a little intimidating.
100%. And being rural, you know, our clientele is more of the Medicare age. And so having them see a physician on a screen is intimidating to them. But I think what has helped bridge that gap is that, yes, they might see that virtual person, that virtual physician, but then it's followed up with our hospitalist. And so there's still eventually a face hands-on that they have appreciated. And honestly, we've had great feedback with it. I mean, you know, the Medicare generation, they were just like, hey, this is pretty cool. But I think without that hands-on and having the hospitalists around as well, I don't know if they would have had the buy-in. And it was the same
Right.
with the nursing staff for sure. You know, they're like, I don't know about this, but what helps is they have built that relationship with these physicians, even though it is virtual, you know, but they reach out by cell, by text now, because we have the same physicians kind of rounding. And so it's like seeing them every day, but it's just a virtual experience instead of like face-to-face.
Okay, good. Thank you. Dr. Ghosh, I want to go back to you. So let's talk about the actual program launch and the steps that go through. So from your perspective, from Access Telecare side, can you describe the implementation process, literally going from day one where you have the contract signing up through seeing that very first patient? What should our members expect as they would go the journey through that process?
Sure. So from the day the contract signs, we determine a go live date, right? So that is a discussion we have with the client, trying to figure out what is our panel going to look like? Is everybody properly licensed? Obviously, we have providers around the country with the large core in Texas, and so with Rush, it was our first Indiana program, and so we had to get Indiana licenses, and so we kind of talk realistically about what that process looks like from a time frame standpoint. When we finally determine what the go live date is, we have what's called a 6 weeks to launch. And the 6 weeks to launch is a 6-week period where we meet on a weekly basis with the client. As Carrie said, it's a lot of meeting heavy in the beginning. And so the very first meeting is a meet and greet with all the necessary leadership and hopefully clinicians on the client end, with our implementation team, our clinical leaders. We go through the process of what the next 6 weeks is going to look like, so there are no surprises. We do a brief discussion on where we are with credentialing for the providers in the hospital. Week 2, we talk about workflows, and the workflow discussion is a very important discussion, because one of the things I've learned over the years launching programs is you want to make sure that expectations are matched, meaning what the client is expecting is what you're going to deliver. If you don't have those expectation discussions up front, it leads to a lot of misunderstanding down the line, where there's a lot of, well, I thought we were going to do this, but we're not doing that. And so that second meeting is really important to establish those expectations. The next series of meetings focus on IT connectivity. Is the hospital ready with Wi-Fi? Is there connectivity in all the rooms? You don't want to have any dead spots. Another meeting is spent making sure that we follow up on all the credentialing. Meeting 5 typically is arranging for on-site training, in terms of virtual on-site training, where we get the nursing staff trained to use the machine, the cart, making sure that they're familiar with what the workflows are. And then one of the last meetings we like to have is what we call hearts and minds. And so, to Carrie's point, you want to have buy-in from everyone. And what we have found is, when you aren't able to do the hearts and minds, meaning our clinical leaders meeting with their clinical leaders and clinicians, again, you have this disparate expectations, where you have an anesthesiologist that's being called at 3 o'clock in the morning for a central line. And this has happened to me before. And the anesthesiologist on the other end, even though we had established that's who we were supposed to call at 3, basically says, I don't know who you are. And then it's a very awkward conversation at 3 o'clock in the morning where you say, well, I'm Preetham Ghosh, I'm the tele-intensivist, and they kind of stop you and they say, what's that? And you come to find out 5 minutes later that that anesthesiologist did not even know that the program had launched 6 weeks prior, right? So those meetings where the clinicians are meeting and talking about what the program is, what it looks like, is what the hearts and minds is. And you're never going to be 100% ready. Are you ever 100% ready for anything in life? You're really not. So
Right.
you try to get to 90% and you say the rest of the 10% we'll figure out. I remember after we launched, I was still the chief for pulmonary at the time. And I had regular touch points with Carrie and other nursing leadership and pharmacy to make sure we had the right protocol. So the launch process, in a sense, blends in with the actual launch of the program, but 90% of it is set before the program actually launches.
Okay. Well, I appreciate your transparency and acknowledging that it is meeting intensive up front, but I also at the same time would think I'd rather be meeting intensive up front than meeting intensive afterwards, trying to figure out what went wrong. So I think your approach certainly leads to the elimination of the conflicts that would otherwise happen. So I appreciate that sincerity on that. Carrie, let me swing over to you. So now you've been, well, you're a year into this now, right?
We opened August of last year. Yeah. So
Okay, so yeah, you're well over a year
Yep.
into it. How are things progressing at this point as far as your expectations? Any surprises? Anything you need?
surprises, no, because we still meet. We still meet monthly. We go over things, and I know they're a phone call away. As far as like I say in the beginning, our transfers have decreased, our surgeries have increased, and the overall patient satisfaction, I think anytime that we have the ability to keep patients here so loved ones don't have to drive, and they feel like they're in that big hospital, big system that they're not used to, and it's closer to home, is our goal. And I think that we have touched many lives by doing that. Of course, from my end, would I love to have more? 100%, but I think this winter will be the true tale if we have more ICU admissions. So
Okay. All right, good. So what do you anticipate when you look at, based on what you've seen in your first year, going forward? What do you see as a long-term impacts for the hospital, for the community as well,
well,
by having this virtual ICU?
For the hospital, even if it's 2 admissions a week in our ICU, it's that downstream revenue too. I mean, the increased surgeries, the increased labs, the increased radiology procedures that come from those more critical patients. And, a lot of times, and being rural, this, you transfer patients and then they get their specialty care up there, but then
Right.
they are set up with appointments up there, where if we can set up appointments down here for follow-up, I mean, that's impactful for a rural hospital. You might not think 2 admissions a week or whatever would be that impactful, but for rural it is. I mean, just because of that downstream revenue that's coming in. So
Absolutely.
yes.
So Carrie, you mentioned in your previous comment, you mentioned the patient experience, and we're all about that. We realize how important that is. So I'll ask both of you this next question. So since you launched that, can you describe any or tell us about any patient stories since you've had the Access Telecare virtual ICU and for your patients, and how that's worked?
I've had great feedback on it that, thank you. I'm so grateful that we did not have to travel, to Indy, because that's 60 miles, and being rural, there's a lot of people who their family members don't even have transportation to travel that far, or won't travel on the interstate. And so I've had a few loved ones, that have reached out and said, you do not know how much I appreciate keeping them here, keeping them safe, taking care of them. And so the burden on us was not there.
Okay, excellent. That's what we like to hear. Dr. Ghost, from your standpoint, have you come across patient stories or examples of success of the program and how that's impacted not only the patients and their families, but the hospital?
Yeah, Phil, I'll tell you, I'm hesitant to give you the wow stories because I don't know, it seems a little too glitz and glamour. And I don't like to do that because I think we all know that having access to specialty care leads to a lot of great outcomes, right? And
Right.
I've been doing telemedicine now for almost 12 years. And so there are abundance of stories, including the patients I've seen at Rush. I'll give you three things. And I really want to focus initially on what Carrie said, because I think what Carrie said is a very impactful statement. So one of our mantras at Access Telecare is to keep patients local. And there are multiple benefits to keeping that. And Carrie's very elegantly explained a lot of it from the financial and from the social aspect, right? There's actually a clinical impact to keeping care local. When you displace a patient from their community, they are then in a system that is unfamiliar to not only them, but to their local physicians and practitioners. So all the care that's being done is being done in a silo, very isolated from their own community, right? The stories are many where you end up seeing a patient in your clinic and they say, yeah, I came into the ICU, I got transferred, then I went to an LTAC, I went to a rehab, then I've got these specialists I've got to see 3 hours away. And you're seeing them 6 months later, and it's almost like they lived another life before you got to see them again. And you can see the frustration and the disconnected, disjointed care they've gotten since that time. There's actually a growing abundance of literature in the medical community about the mortality and morbidity impact of transfers. Because of this disjointed, distant care, you actually increase mortality, morbidity, and hospital readmissions, right? And so that's something I want everybody to kind of understand, that we are very much focused on the return on investment for our clients in order to have them feel like their investment is worth it from a financial standpoint. We also want to make sure that the patients in the community are feeling a return on investment that is clinical and more social on their end as well, right? From a story standpoint, I'll tell you, there are two groups of stories that I think I can relay that really highlights the impact of telemedicine in general, not just critical care telemedicine. But the first one is one of the greatest things you see as a provider in a virtual visit is when you see a nurse who is really itching to take care of sick patients, especially in a hospital where they haven't had that. And you see the learning curve, and you see them hit that learning curve, and they are excited to not only take care of the patient, but to learn more. And within a week or two, you start to see their growth, their development, their comfort level in taking care of sick patients. When COVID hit, we had nurses in rural hospitals that had never proned a patient in their life because they'd heard about it. They did it when they were in nursing school, but they never actually did it. And I remember we were in a rural hospital in West Texas, and I told the nurse, I was like, I think we need to prone this patient. And she looked at me, she said, let's do it. I said, do you guys have a protocol? She said, nope. I said, well, I'll walk you through it then. And we did it. 3 weeks later, in a 6-bed ICU, we had 4 prone patients. We had a protocol in the hospital, and every nurse, day shift, night shift, knew how to prone a patient. That, to me, is a story worth telling, right?
Yeah, that's a success story.
That's
Absolutely.
a success story.
Okay.
I think the second one that I want to briefly talk about, and we saw this a lot during COVID, but I realized this very early on in my telemedicine career, is the role that we have as palliative care physicians. So patients end up in the ICU, you know, as a clinician, what the outcome is going to be. But providers on the ground who are not specialists are uncomfortable having conversations that deal with end of life because they don't know whether they are the ones that should be having those discussions. They don't feel comfortable talking about the statistics that families are asking about. That's a massive impact when you can have an end of life discussion with a family and a patient, because you are not only giving them dignity, but you're giving the family comfort and you're giving the hospital a reprieve from length of stay, expenses that really are unnecessary given what should happen versus what might happen. So
Okay, good.
no glitz and
Excellent
glamour
explanation.
stories, just, kind of more, thematic, impactful stories.
Which are greatly meaningful to us. So Dr. Gross, I want to stay with you. You and I spoke a couple of weeks ago, and I want our members to be able to have some level of estimations of the numbers that would be applicable to them. So I think I asked you, I said, if there was a hospital that averaged 12,000 ED visits per year, approximately how many, from your experience, of those 12,000 would ultimately become candidates for the virtual ICU?
Yeah, so I actually looked at Russia's number in particular, right? And so I know that they are, before we arrived, they were transferring roughly 8 to 9 patients a month for pulmonary reasons. So there were no admissions, obviously, because they're all being transferred, maybe 1 or 2 here and there, but not ICU level, probably more basic pulmonary. Their transfer rates have dropped 39% since we've arrived. Now, if you look at their transfers for pulmonary, it's anywhere from 0 to 2 a month. So that's down from 8 to 9 a month. You're with Rush, we developed an ICU, right? So we developed a 2-bed ICU. Now, depending on how many beds you have, that will dictate the number of patients you can keep or not keep, right?
Okay.
And so really that number is dependent on the number of ICU beds you have, to be honest with you. So you could bring in 12,000 to a facility that has 6 beds, the number is going to be a little bit different versus 2 beds, the number is going to be different. But if you look at a 2-bed ICU and you look at a transfer rate that's dropped close to 40%, that gives you a rough idea of the impact that numerically that a program like this can have.
Okay, good. Very helpful. I appreciate that. So Carrie, what type of staffing needs are there? So when you launched this program, did you have to make changes to your staffing? Did you have to add? Did you shift? How did that go?
So we had the benefit of our ICU is pretty much connected to the med surge. So the overflow of patient care techs is there, but then we went out and we did hire 3 FTEs with ICU experience. So it, that cost did increase. We were not at respiratory being here 24/7. It was more 12-hour shifts and then on call at night. And so we implemented that, having the respiratory here 24/7. So as the cost, we did have to increase our FTEs for nursing care and respiratory. But in the end, being connected to the med surge, we have a lot of floating going on too. And so I feel like it has been kind of cost neutral in a way, just because those nurses in ICU can float to med surge if we have a call in and we don't have ICU patients.
Okay. And in addition, yes, you've had some additional costs, but you also referenced the downstream revenue because of the labs and the other services that you've done that would certainly generate revenue. And those ICU nurses, or the experience that you hired, those 3, can be used in other departments as well. So
other departments, and just like you say, them having the knowledge and helping the med surge nursing staff feel more comfortable if they have to go over there and help.
Right. Okay.
So it's a win-win for sure.
Good. Good to hear that. Dr. Gillis, one last question for you. What are the most common diagnoses that present that wind up going into the virtual ICU?
Yeah, so we are fairly particular, yet we push the envelope on who we accept. It's a delicate balance. Top top three diagnoses would be acute respiratory failure, shock, and probably diabetic ketoacidosis, especially in a rural setting. In fact, the first patient I saw at Rush was a DKA patient. There's a fourth that I would say, I know you asked for three, but I'll give you a fourth. There is obviously a growing abundance of opioid overdoses and abuse. We do see a fair bit of overdose patients in rural settings. There's, a lack of mental health support, lack of resources. And so we do see a lot of overdoses. So those would be the top four, I would say.
Okay, good. Thank you very much. Appreciate that. Well, I want to thank our guest. I want to thank Dr. Ghosh. I want to thank Carrie Tressler for joining us today. It's been a wonderful relationship that we have had at the IRHA with Access Telecare. I know that when it comes to selecting a partner to work with, that character of the individuals is extremely meaningful. And I've had the pleasure of working with John Henry from Access Telecare now for 3 or 4 years, and just continually find him to be highly credible and honorable. It means a lot to me when I roll somebody out in front of our valued members, that it's somebody that I'm confident is going to represent not only their own organization, but the IRHA as well. And I cannot say enough about John Henry, just like we heard with Dr. Ghosh, very, very transparent. They tell you everything up front. They don't sugarcoat it just to get attention. They just tell it like it is. And so we're very appreciative of that. So are there any questions from the audience before we leave today? All right, well, we have recorded this session, and I will send the recording link out as soon as that is available to all of you. Feel free to share that with members within your hospital, and we can provide contact information for both Carrie and Dr. Ghosh and John Henry. So any questions you have that you wanted to ask privately to them, I'm sure they'd be happy to answer. But I want to thank everyone for being with us today. Dr. Ghosh, Carrie, I cannot thank you enough for sharing about the experience. This is an exciting opportunity to enhance the patient experience and keep patients local where they want to be. So thanks everyone for being with us today. Enjoy the rest of your day.
Thanks all. Bye, Carrie. Thanks, Phil.